This is HealthCall Online, the place for extended versions of interviews you hear on our weekly radio broadcast, the HealthCall Radio Hour, now heard on more stations around the country through national syndication. We begin today with a look at a milestone in medical research that could come maybe later this year, at least in the near future, when a liver harvested from a pig is used to keep a human alive. You know, there is a significant shortage of organs for transplant. Thousands of Americans die each year from end-stage kidney and liver disease because organs simply aren't available. Could this be an answer? Well, a company called Miromatrix Medical certainly hopes so. And let's learn more about the science behind this, and then we'll dig into some of the ethical issues as well. Talking to the CEO, Jeff Ross, joining us from Eden Prairie, Minnesota. Jeff, thanks for dropping in.
Lee, it's a pleasure to be here.
Give me just a big picture here. Tell me more about what's going on with the liver that you hope to use with the human and what makes it different.
Yeah, I think the key to our technology is, if we back up a second and just introduce you to Miromatrix in general, our mission is to eliminate the organ transplant waiting list. And the way that we look to achieve that is actually through bioengineering transplantable human organs. So as you stated kind of in the intro, you know, our lead product today, which we already submitted to the FDA to initiate our human clinical studies, is actually to take our bioengineered liver, house that outside of a patient to be able to actually treat them for an acute liver failure. But if we dove in for a second and describe that a little bit more, I know you described it as taking a liver from a pig and utilizing that in a human. That's not quite completely correct. Because if you look at our process, we actually start with a pig organ, and many of these would naturally be discarded as part of the food cycle today. And we use the first step of our process called perfusion decellularization. That's essentially where we hook the organ up, we flush a solution through it, and we remove all those pig cells. So we're able to essentially flush out all the cellular material, and all that you're left with is really the structure. And here's a kidney that has been decellularized. And what you can see is it's completely white at that point, because all that's left is the protein structure, the architecture, the vasculature, kind of that microstructure that makes a kidney is there, but there's no pig cells left. As a second part of our process, we actually take cells from human organs that weren't placed for transplant. These can be cuts, nicks, tears, long ischemia time, a host of reasons why that couldn't be used to save a life at that point. We receive that at Miromatrix now. We isolate out those human cells, and now we take those human cells from a liver, or for bioengineering kidney, from a kidney, place that back onto the matrix to be able to now create that bioengineered organ. So when we look at it, it's truly a bioengineered organ, because while we are utilizing the scaffold from an existing organ, it's being really recellularized with human cells.
So you're not really putting a pig liver into a human. You are using the scaffold, the framework of the pig liver infused with human cells to perform that critical function. So how do you get the human cells out of those organs for donation that weren't acceptable for use in humans? Is it the same process, sort of a detergent wash? How does that work?
Yeah. It's kind of an inverse of the process. If you think about that first level, right, you described that as a detergent wash. The decellularization, we infuse something into the organ to remove all the cells, essentially dissolve those, and we push those out. When we're isolating the human cells, we actually go in and now add proteases or other things in there to actually dissolve the matrix and then preserve the cells. So it's kind of the exact opposite process, because at the end of that process, we're left with all the human cells, you know, all the cells that made up that liver, or all the cells that made up that kidney. And now we're able to take those cells, introduce that into a pristine matrix that's, you know, essentially the similar size to a human organ, vascular density, and then allow that to recellularize as part of our second step of our process. And then that's that bioengineering that organ.
Fascinating. We're going to dig into that a little bit more in just a second. So in the trial that you hope to get moving forward, where you're using it for a human, walk me through how that's going to work. If I were in the room, what would I see?
Yeah, I mean, what we're excited about this first product that we have going forward is utilizing our bioengineered liver prior to moving forward with a fully transplantable, is actually house this outside the patient. And what we're looking to treat here is patients with acute liver failure. Today, there's no therapy for acute liver failure outside of transplant. So unfortunately, those patients who present today with advanced stages of acute liver failure, 30% of those patients are going to die 25% of those are going to be transplanted and get access to life-saving technology. And about 45% of those patients are spontaneously going to recover, because the liver is the one organ in the body that can actually regenerate itself. So our hope on this is by utilizing our liver external to these patients. We announced in February a collaboration with Baxter, where we're utilizing their Prismax instrument to provide that circuit where we're able to draw blood from the patient, bring that up, move that through our bioengineered liver, and then return that blood to the patient is the plan there, to therefore provide that patient with liver function while their liver is failing. And the hope from that is, at a minimum, it becomes a bridge to transplant. So for those 30% of the patients that unfortunately die, can we give them a longer time to be able to receive a liver? Now, our true hope of this, and where we continue to see data go and stuff like that, we need to prove out in the clinical study, is that this would actually be a bridge to recovery. Can we provide liver function long enough that that patient now own liver can recover, and then that patient can go on to a full recovery and no longer need a liver transplant, which in that scenario would potentially free up that 25% of the patients today who are getting a transplant, free up that liver to go to someone else as well.
So essentially, your liver would be performing a similar function to dialysis, where blood is taken out of the body, cleaned, and then reinserted, replacing the function of the kidney. You're going to do the same thing with the liver in a biochamber.
That's absolutely correct. It's a good way to look at it. Is essentially this is liver dialysis.
Yeah.
But unlike renal dialysis, that's through a membrane or a filter, we're actually using a bioengineered liver to be able to provide that functionality for the patient. And the difference between renal dialysis and liver dialysis, as we're looking at it, is, renal dialysis, you need to do this 3 times a week or up to 3 times a week for those patients.
Right.
Because the liver is the one organ that can recover or regenerate. The hope is this is a one-time therapy and that you wouldn't need repeat therapies of this once that patient's able to recover.
Oh, let me drill down on that. So you're saying that I'm going to have a period of treatment on your engineered liver. How long is that treatment going to last? Is it days, weeks, just once?
Yeah, we're looking at days for that. So an acute liver failure patient would present. They have a window for therapy to be able to provide them that liver support. And, our belief is, and something that we'll be looking at in the clinical study, is we think multiple days therapies, not weeks therapy, will provide that level of functionality to allow their native liver, hopefully, to recover to the point that, again, they no longer need therapy, or, make that call during that time. Yes, this patient needs a liver transplant long term, but here now we have a window to be able to provide time to procure that liver much more than what's available today.
Man, this just kind of blows my mind that you can take those human cells, put them into a framework, a scaffold that they've never seen before, and they just know where to go and how to function. That's amazing.
Yeah, I think that's really the beauty of the technology. I mean, as you look at this, and certainly we've developed this through where we've been in the history of the company. It really started with first proving that, yes, we can start with a porcine matrix. And we took whole porcine livers, used our process called perfusion decellularization, removed all the cellular material, and created a surgical mesh that was for soft tissue reinforcement. We also created a biologic wound product from the decellularized porcine liver. And part of that was there was a need for new products, and we filled that gap. But the other part of that was to demonstrate the safety profile associated with that. So we used the 510K process to be able to get that product cleared. And that product has been transplanted into thousands of patients today. So, we built a good framework on the matrix by itself. The next steps was to introduce the cells. And as you mentioned, how do we know that the cells go to where they need to go?
Yeah.
And, we've certainly worked through that process, and we've published on that in Nature Biomedical Engineering and other lead journal articles that demonstrate not only that we can place the cells back into the matrix, into the appropriate spot, and they naturally go to where they should be, but also we can see the functionality. So we can, transplant that back into a large animal model like a pig and demonstrate not only we get long-term perfusion or blood can flow through that organ, but we're also seeing some of the functionality that we would expect from that organ as well, which has all really led us up to this first step that we are right now in filing our IND with the FDA to get that clearance to be able to move forward with our first human clinical study.
So did I just hear you say that you've taken the engineered livers and put them back into a pig? And how long do they last if that's the case?
Yeah, we've done some acute studies on that, looking at kind of both from a perfusion standpoint. So the first step was, can you solve the vascular challenge? So for years, if you look at tissue engineering, a lot of promise, because, the promise of tissue engineering is instead of just treating the disease, can we cure a disease? Can we actually, if someone's got damage or diseased tissue, whether it's a liver, whether it's a kidney, whether it's a heart, all sorts of things, can we essentially create that tissue? So instead of treating it, can we actually transplant something new? And if you look at the evolution of the field, they've really been held back in tissue engineering to very thin tissues, a couple of millimeters in thickness. This is skin grafts and other types of tissues, because they don't have intact vasculature. The reason they're a couple millimeters is any nutrients that those cells need to actually diffuse into that tissue, and any waste needs to diffuse back out. The purpose of our vasculature partially is to bring all the blood supply and nutrients to our cells and allow them to get out of waste. So what we demonstrated as that first step was that we could actually take the decellularized organs, place human cells back into the vasculature. These are called endothelial cells onto the surface of that, and essentially transplant that back into a large animal model like a pig. And we demonstrated that we could get, perfusion for weeks in that model. That's what we published in Nature Biomedical Engineering. So we really demonstrated, the vascular functionality, the ability to move these things forward.
Amazing. In the end stage, if we're successful and it comes to implanting that engineered pig liver back into a human, am I going to have to be on any type of rejection medication? Is there any additional medical support I'm going to need, or is the function so complete it's not going to be necessary?
Yeah, it's a really great question. As we look at this, we're looking to as the first stage, or the first product, is we're bioengineering allogeneic human transplantable organs, which means these should be similar to whether it's a living donor or a deceased donor. So the intent is those patients would still need to be on immunosuppression for, the first level. But to give you a sense of the need that exists out there, there's about 115,000 patients today waiting for an organ. It's going to be about 40 to 45,000 transplants this year, which means 70,000 patients have already gone to their physician. They've been pre-screened. They're waiting for that phone call. They're okay with immunosuppression because they need life-saving technology, and they're not going to be able to get it. So, for our first step is how can we get that to them as quickly as possible? And by utilizing, primary human cells that have not been genetically modified, they haven't been changed, provides us that fastest process to be able to get those organs to those patients. And that's our hope. And then once we're there and we're saving lives, then we can invest in that second generation, whether that's from a biopsy from the patient, whether that's stem cells. The true potential, long-term potential of the technology is eventually to be able to create organs that would no longer need immunosuppression. But that is much further in the future.
Yeah, as we get closer to being able to create stem cells that are neutral in their immunogenic reaction, right? So we can have stem cells that we can mass create and use for many purposes without that process. Let's hope we get there soon. So
and we're looking at multiple fronts on that. I mean, certainly there's a stem cell avenue. I mean, to give you a sense, one kidney that comes in today, one deceased donor kidney that wasn't placed for transplant, we isolate out the human cells out of that. That can give us up to eight transplantable, we believe, eight transplantable bioengineered kidneys today. Wow. One liver, we're seeing up to 4 liver grafts in some cases as well. So you can start to see that it's not a one-to-one. There's actually an expansion factor in there, which allows us both to, in the future, once we're successful with our first product, to then look at a stem cell based, or as I talked about before, potentially biopsying the patient's own organs, getting enough of a cellular mass there to be able to engineer something. Now it's that patient's own cells.
Right. Yeah, I get that. That would be tremendous. So let's talk a little bit about the ethical side of this. You said that currently you're using human organs that are not eligible for transplant. I get that. So that supply makes sense. Where are the pig organs coming from, and are you going to run into opposition from animal rights activists?
Yeah. So, as part of our process, and certainly because we already previously commercialized a product as well, and that product's still on the market being sold by Reprise Biomedical, is we actually receive organs as a byproduct of the food cycle today. So many of these organs, and part of the process is we work with processing plants that have the certifications to be able to provide this from a medical grade standpoint, but those animals are still being utilized for food. So we believe that kind of bypasses the ethical issues, at least at a high level, because we're planning to utilize organs that naturally we're either going to be discarded, go into rendering, or other things. So we're trying to take something that's a byproduct and create life-saving technology associated with it.
Got it. So the liver is a very complex chemical factory with lots of different functions. How completely does the engineered liver replace those functions?
Yeah. So that's something that we've certainly tested a lot on the bench and looked at it. We can demonstrate we get urea production. We can demonstrate that we get ammonia clearance, which is a big one. The liver is the only organ inside the body that can clear ammonia. So we can spike in high doses of ammonia and we see beautiful clearance with that. We got albumin secretion. And then we looked at a whole host of other factors. So I'd say, we've looked at a large number of functionalities of the liver. And when we tested in our bioengineered liver, we're seeing that level of functionality. So the next big test is, really to be able to move this into the human clinical studies and demonstrate that level of support in an acute failure condition and demonstrate that our bioengineered liver can provide that liver support to the patient.
We've talked a lot about livers. Kidneys you're also working with. They, it seems, would not be quite as complex from a chemical process, but metabolism, all those things. Is that an easier organ to engineer, develop, and implant?
Yeah, great question, Lee. It always depends on who you're talking to. So it's amazing when I talk to liver experts, or you'll hear, why are you starting with the hardest organ? Like kidney's really easy. Yeah. When I talk to the nephrologists in the kidney field, they're like, why are you trying to tackle kidney? You know how complex kidney is? You should do liver. So I would say each organ, has its own challenges and stuff like that. I think the beauty of our process and our first step that we are isolating human cells from organs that weren't able to be transplanted. We know that we're getting the appropriate cell types that have the functionality to provide that to the patient. The liver is less overall cell types or stratifications in there and stuff like that, and it does a lot of function. The kidney, a lot of microstructure and a lot of different cell types. So by really isolating it from an existing organ, placing that in the pristine matrix, that's really our first step of that approach to ensure that we get that level of functionality back. And that's what we're able to test on the bench, which is the beauty of bioengineering organs like this is, once we recellularize them, now we can put in some of those quality control measures where we're looking at that functionality as part of the release to ensure that if we are releasing an organ, for a clinical study or eventually, hopefully once the organs get approved, following that is there would be stringent quality control measures to make sure they have the functionality before they even leave Miromatrix.
So I'm thinking of other organs that this process could apply to. The pancreas comes to mind. If I'm diagnosed with early stage non-metastatic pancreatic cancer, or potential replacement for elimination of diabetes, is that even a possibility?
Absolutely. I mean, if you look at any of the vascularized organs inside of the body, the technology and approach could work really, really well for, whether that's pancreas, whether that's lung, which is another great application, whether that's heart. We really chose liver and kidney as the two lead products, really based out of need. If you look at liver and kidney, they make up over 90% of all organ transplants today. For liver, there's no alternative therapies. There's no drugs, devices, dialysis for them. So a really big need that we want to fill. And we know on the renal side or the kidney side, we have over 500,000 patients who are on dialysis today. 5-year mortality rate of dialysis is 50%. Quality of life we know is challenging. Contrast that with a transplantable kidney. The mortality rate at 5 years is less than 15%. Those patients have a high quality of life. So, we're really looking both at, as with resources, what can we focus on? How can we have the highest impact? Once we're successful there, I think you'd see us start to expand in all those other organs.
It's a fascinating process. The work you do is so interesting. I'll be watching it closely. Anything you want us to know before we say goodbye?
I think just appreciate the time today. And, we're excited about changing the future of transplant. We really see ourselves as pioneers inside of this space to try to change one of the largest unmet needs we think is in medicine today. How do you create that future where patients aren't waiting for that phone call? Mm-hmm. Instead, they could schedule weeks out in advance when they're going to get their, organ. And, that's the future that we believe in. That's the future we're driving towards. And we're working hard to get there.
Interesting conversation. Thanks. That's Jeff Ross, CEO of Miromatrix Medical.